this one, and this is 2 pointer. You have to point here or you point here? There? Okay. Thank you, Dr. Nada, for the invitation, and thanks for the panel, for the introduction. I prefer the term therapeutics than interventional, because intervention is just only something like to perform new procedure, but the new procedure are also a way to perform some types of therapy that can be done under EUS, because two simple things that characterize EUS is the capability to see outside. So I can see outside the wall, behind the wall, things that normal endoscopy cannot do it. And it's a minimally invasive procedure that can easily reach, and this is a very important concept, can easily reach sites that are otherwise difficult to be reached. And if you do a therapy, the therapy can be repeated if necessary. If you talk about sites easy to be reached, you talk about the mediastinum, that clearly is a very difficult site to be reached otherwise, the retroperitoneal organs and lesion, and also the pelvis. So the revolution of therapeutic EUS has been the introduction of lumen-opposing metal stents. This has been invented by Bim Möller, who is an endoscopist, an American endoscopist, who designed these stents to drain gallbladder. So his idea was to perform a communication between the gallbladder and the GI tract, and then afterwards this was applied to other conditions. But the real revolution in my mind was the introduction or the design of a cystotome on the tip of the catheter that allowed to perform basically a one-step procedure. So you, instead of doing needle, guide wire, dilation, stents, with the new lamps, that is the hot axis or the spaxus, you can basically go inside without using any other devices, and you can do everything under EUS guidance. So you don't need fluoroscopy, even though fluoroscopy can be useful in case of complication. So what you can do, it's pancreatic fluid collection, and this has become basically the standard of care. You can do choledochondrostomy. This is basically done from the duodenal bulb into the distal bile duct in case of malignancy, and now there are many randomized trials that basically has demonstrated that choledochondrostomy is the same as standard ERCP. There is the possibility to perform gallbladder drainage in patients who have acute cholecystitis, but you can also do in other type of patients. I started doing elective gallbladder drainage, so in patients who come back to the hospital with the recurrent cholecystitis, and the surgeon doesn't want to touch them because they have a cardiac problem, a respiratory problem, you can drain the gallbladder. And then gastroenterostomy, so anastomosis between the stomach and the duodenum, or the first part of the jejunum in a case of gastric outlet obstruction. In case of gastric outlet obstruction or in case of altered anatomy, you can also perform now hepaticogastrostomy. So you basically can drain the biliary system completely. In fact, you can also do from the right side, or through the stents or through the access. You can also pass a guide wire in the right system, put another stent, and basically drain the right and the left lobe of the liver. So therapeutic EUS, intratumoral therapies. This is an insulinoma. This is a 13 millimeter insulinoma close to the papilla in a patient clearly symptomatic who was operated for a previous insulinoma of the tail, but in reality was not an insulinoma. So this is radiofrequency ablation. So you ablate one portion of the lesion. This is still not ablated. But then you can remove the needle, position it in this part, and ablate all the lesion. So for insulinomas, for functional neuroendocrine tumor, I think this will become the standard of care. You can also treat functional, non-functional tumors, 13 to 18 millimeters, with certain criteria that has to be discussed with the patient. But clearly, you have to also balance what you will what will you do instead. You will do a surgical resection of the pancreas that has a lot of mortality and morbidity. You can also use, now there are some trials, ongoing trials of association with the neoadjuvant therapy in patients with the pancreatic adenocarcinoma. You can use for metastasis of the pancreas from renal cell carcinoma in recurrent G1 tumor, and I think there are other options, other indications that can also be done in the future. So in this case, is a tumor of the pancreatic head in a patient with no response to therapy. This is a lesion from a metastasis from renal cell carcinoma. This is a recurrent ovarian tumor in the pelvis. And in this case, it is a pancreatic cyst in a patient who was old and with comorbidities, with nodules that were proven by contrast, in whom basically we approach with the radiofrequency ablation, and the data now on the literature are pretty good. Other things that we can do with the EUS brachytherapy. So alpha, beta, and gamma. Gamma are used clearly in radiation oncologies, and the ionization, so when it's external versus internal, and the penetration varies. So the penetration for alpha is lower than beta and the gamma. Actually, there are some studies with the Oncosil, which is a company from Australia that use beta radiation brachytherapy. So what you do, you inject in the middle of the pancreas. You calculate the dose before by doing a volume studies of the lesion, and this is the results. So all the compound is there, and basically in this way you are able to give with a single injection more than 90 gray of radiation. This is the first study published, and now there is also a company from Israel. The alpha tau that use alpha radiation, and basically you have to put these seeds through the lesion, and these are all the radiation is basically minimal, so you don't need to conserve these seeds in the nuclear medicine. You do a study with the volume, and also you study with the physical medicine the distance. You place this, and this destroys the tumor. Actually, there are cases of disappearance not only of the primary lesion, but also of metastatic lesion because of abscopal effect. This is to finish. You are all invited to follow on December 5th the event that now is on the 4th edition, US Skyline, dedicated this year not only to US but also to ERCP. Thank you.
Yes. Thank you for all speakers.